Let's talk about apicoectomies. There's always the conversation if a tooth has had endodontics already, and the endodontics has failed, and now you have granulation tissue or granuloma at the apex of the tooth because of failed endo. Do you extract the tooth and place an implant, or do you try to save the tooth with apicoectomy? An apicoectomy is highly successful if performed correctly. An apicoectomy is a lot less trouble, a lot less expense, and a lot less morbidity than an implant, especially in the anterior or aesthetic region. The other thing is, with an apicoectomy, I can always fall back on an implant if for some reason it didn't work. Say the tooth was split vertically and you couldn't tell on the radiograph, and you eventually lost the tooth that had the apicoectomy. You can always go back and do the implant later. It's like a second parachute. So I hate to pull my second parachute until I have to. So in this case, this gentleman had crowns on the maxillary anterior teeth, some implants here. The lateral incisor had previously had endodontic treatment, and now he's developed an infection, pain, and the fistula has blown through the gingival sulcus right here. Tooth is about class 2 mobility. You can see we've had endo and a post. Now you worry in a case like this that the tooth may have a vertical fracture, but it seems like it may have a horizontal fracture, and often the horizontal fracture is right at the tip of the post. So I'm wagering that is the issue. You can see the granulation tissue here at the apex of the tooth. So the distance from the incisal edge of the tooth to the apical aspect of the tooth is approximately 26 millimeters. This gives me a guide once I've reflected the tissue, if the bone is covering the entire tooth, of where I'm going to make the osteotomy in the bone to remove the apical part of the tooth. It's very important in these situations that you numb the palate or the lingual as well as the facial. And this is an intraligamental intrasulcular injection, starting out with Sitness plain and then either lidocaine or marcaine with vasoconstrictor. So here we're measuring. The incision is not in the sulcus, but it is in attached or keratinized gingiva. Now, why not make it in the sulcus? You make it in the sulcus on the facial of a tooth in the aesthetic zone that has a crown or a veneer. You may get just a little bit of recession and expose the margin. So never make the incision in the sulcus in the aesthetic zone. Now in the posterior, it's not that big a deal. I generally make it in the keratinized gingiva though, and not the sulcus, even in the posterior part of the mouth. This is the full thickness incision beginning up here in the non-keratinized, non-attached gingiva and extending into the keratinized attached gingiva. It's a semilunar or elliptical incision. And I make this incision above the defect. I want to reflect past the defect, and when I suture, I don't want to suture right on top of the defect. I want my suture to be coronal to the defect. This is a periosteal elevator. An apicoectomy is not a difficult procedure, especially if it's on a single rooted tooth. Now where you get into complication, and you don't want to touch these, second bicuspids, mental nerve, don't go there. Lower molar teeth, inferior alveolar nerve, don't go there. Upper posterior teeth, good. You can perform apicoectomies on the facial roots. The palatal root, don't go there. It's very difficult to access, but you can access the facial roots, the buccal roots, quite easily. bicuspid teeth in the maxillary anterior, cuspids, incisors. Very good. Go there. Lower anterior teeth, cuspid to cuspid. Good. Do those because you can access the roots fairly easily through the bone. But the ones you don't want to touch are the bicuspids back, the bicuspids in molar teeth, mandibular arch, and palatal roots of maxillary molars. Send those to a surgeon or an endodontist. You can live a perfectly good life and never do an apicoectomy on those teeth. Stick with the maxillary anterior and bicuspid teeth, buccal roots of the maxillary molar teeth, and the mandibular anterior teeth, cuspid to cuspid. Full thickness flap. Now what we'll like about this, it makes it quite easy. This buccal bone in the maxillary anterior area is normally very thin. So I'm reflecting all the way to alveolar crest with this part of the incision in the keratinized attached gingiva when possible. It's not the end of the world if it's all in unattached, if you don't have enough attached gingiva. But if you can, keep it in attached gingiva. Now here's the fistula right here. That's actually very firm tissue to the point I've got to incise it with a 15-barred Parker. I couldn't reflect it with my periosteal elevator. So I'm sizing this all the way to bone, and you'll see the fistula through the bone right here. And often that's the case. If you have a blowout like this from a fistula, you know you're going to have a hole in the bone where the fistula or the infection came through the bone. Now this is a number 4 or 6 long-shanked surgical round burr. High speed, lots of water, very light touch. And what I'm doing is just removing the bone around the apical part of the root. And I'm beginning at the hole in the bone. And I'm just uncovering the root of the tooth very lightly. Now this is a number 4, a small round burr. You want a long shank so you can see what you're doing. If you've got a little short shank, the handpiece is in your way and you can't see what's going on with the burr itself. So you can see that's where everything blew through right there. You'll probably end up with some recession right here. Okay, now this is a flame-shaped fine diamond burr. I'm cutting through the root of the tooth. I'm probably 3 to 4 millimeters from the apex of the root, and you'll notice I'm cutting at a bevel. Now be sure you get all the way through the root of the tooth. Actually go into the alveolar bone just a bit on the other side of the root to be sure you've cut through it completely and don't leave a little lip of tooth on the palatal aspect. So lots of water, high speed, a bevel. The reason you cut a bevel and not straight through, it's easier to put your retro fill material into a beveled cut than a cut that's perpendicular to the long axis of the teeth. So make that cut beveled. So you want to make this cut coronal to the granulation tissue. The reason for that is if the palatal part of the root is apical to the granulation tissue, you can't get your spoon in there to curette out that granulation tissue. It's very important that you curette all the granulation tissue out of the defect. So to do that, you want to cut the root off coronal to the granulation tissue. Now that is another consideration when considering a apicoectomy. If you had this giant granuloma extending coronally most of the root, then an apicoectomy may not be an option. It's very important when you get through with the apicoectomy that you've got enough root left that the tooth is stable and not mobile. You could always splint it to the adjacent teeth if you needed to, but that might be an indication to go ahead and extract the tooth and place an implant if you did not have enough remaining root structure to stabilize that tooth following apicoectomy. Okay, so we're removing enough root that we can get to all of the granulation tissue with our spoon. So cut all the way through so that this piece is mobile. The way I know when I'm all the way through, I'll test it with my burr. I'll just move it and see if I can move that piece, because once you've cut all the way through, you should be able to move it. There it goes, see it moving? And many times when you do an apicoectomy, you really don't know what caused the problem. You really don't know what caused the problem. I can't wait in future Dental Minute videos when we talk about the patient conversation, because life is not without risk, and part of it is their choice. Do you want to have a go at this apicoectomy, realizing there is a chance that it could fail, and then you have to have an implant? Or would you rather go straight to an implant? And as we discussed, an implant is not without downside. So let the patient understand that nothing is perfect. Don't ever forget there's not any dental procedure that cannot fail. There's not any dental procedure that cannot fail. And some of these are very predictable, but as we get into the more complex cases, as we move through the Dental Minute teaching series, restoring complicated situations is like restoring a NASCAR, a race car. You can restore it perfectly, but the person driving the car can cause a breakdown. So we'll talk more about that patient conversation and how the patient is a part of the decision-making process, because you can't guarantee everything you do is going to work. Really, you can't guarantee anything you do is going to work. Luckily, dentistry is a highly predictable field. I'm very happy I'm in dentistry and not in medicine. Our predictability is a lot higher than our colleagues in medicine most of the time. Okay, so again, with this high-speed number 4 long shake round burr, I'm just going in and barely touching the bone, not much at all, but I'm just removing all the crud, all the granulation tissue from that defect before I come back with my spoon and really curette it. This is just a large spoon, and you can see there's still a little lip on the tip of the root. So I'm going to come back here in a minute and cut that off so I can ensure that I'm getting all of the granulation tissue out of the defect. My bevel is not as extreme as it was previously because I don't want to remove any more of the root on the facial or the bone on the facial. See, so now I've got access to all the granulation tissue with my spoon. For a procedure like this, I normally schedule about an hour. So now I've removed most of the granulation tissue and I'm down to alveolar crest. Do you fill the defect or do you not? I like to fill the defect with either artificial cancellous bone with a membrane or platelet-rich fibrin. Now in this case, we're going to fill the defect with platelet-rich fibrin. Main thing about platelet-rich fibrin, it's full of growth factor, and enhances healing. Then I'm going to come back with something to wipe it out with a small cotton ball or large cotton ball. Either Paragard, water, whatever you want to use, just to wipe it and clean it out real well. Last little remnants. This was Paragard, which is chlorhexidine. Now the mobility of the tooth has not changed. It's still about a class 2 mobility. And what do you tell a patient about an apicoectomy? About the prognosis of a tooth with an apicoectomy. I tell a patient there's a 50-50 chance you'll have this tooth at least 10 years. Now, I think the probability of them having that tooth 10 years with an apicoectomy is much greater than that. But I want them to understand the risk going in, and I write all this down and they sign it, that you have about a 50-50 chance of this tooth lasting you 10 years. You could, what's the worst case? Worst case is you could lose the tooth in a fairly short period of time. I've never had that happen. If, a case like that, if that happened, I think it would be from a vertical fracture that I probably would discover once I removed the bone and began the apicoectomy, and I'd explain that to the patient ahead of time. You can decide what you want to do. You might say if you lost this tooth within a couple of years, I would apply half of the cost to your implant. The motivating factor for the patient to have an apicoectomy, as in my case, with the tooth I lost, I had the injury when I was 17 years old. When I was about 45 or 50, I had an apicoectomy. I had the tooth finally extracted when I was 58, 59. So it bought me another 8 to 10 years on a very compromised tooth. But you need to have this discussion with the patient because it's not a slam dunk. It's not an automatic that it'll work. What you're trying to do is postpone them having to have an implant. And it may never occur, or it might occur pretty quickly, but talk about what happens if the procedure failed and they lost the tooth. The reason it would fail is because there's something wrong with the tooth that you just were unable to uncover, primarily a vertical fracture. Now I'm going to draw blood for platelet-rich fibrin. This is ethyl chloride cold spray just to make the needle prick more comfortable. You see the blood comes up into this holding part of the needle. The vials have got negative pressure or the vacuum, so they actually pull the blood into the vials. There's no chemical in the vials. Now in this case, I'll probably just draw 2 vials. The most I draw is 6 for no good reason other than I've not had a need for more than 6. But usually I'll do 2 to 4 vials depending on the extent of the surgical procedure. So once we draw this blood, we're going to put it in a specific centrifuge and spin it down to form the platelet-rich fibrin clot. You leave the tourniquet in place while you draw the blood, and be conscious of how long the tourniquet has been on the arm. You really don't want to leave it on there more than a couple of minutes. Apply pressure for, if it's a vein, for a couple of minutes. And you're drawing the blood, of course, from the vein, not from an artery. Very easy. You centrifuge for 8 minutes. Now, I would say probably 70-80% of the time we do it twice, 8 minutes, and then we spin it again. If the clot doesn't form after 8 minutes, you spin it again, and I've never had a clot not form after the second spin. So a total of 16 minutes in the centrifuge. This is a long shank 1/2 round burr, and I'm opening the apical part of the root where the endo filling was present to make a opening for my retrofill. Probably 1 millimeter or 2 into the tooth, like a little foxhole. But you can see why it's easier to place the retrofill to cut the hole with a beveled cut on the root of the tooth than a perpendicular cut. This one has gotten a little more perpendicular just because I had to remove more root structure on the palatal part. This is called Brasileir Endosequence Bioceramic Root Repair Material. And it's good for repair of root perforations, root resorption, root infilling, apexification, and pulp capping. One of the issues you'll have with filling the apical part of the root is bleeding. So sometimes I'll put large cotton balls in the defect and then pressure here on the facial if that's a problem. Keep the tip of the syringe all the way to the bottom of the hole and let it fill up. Don't move it up and down because you don't want to incorporate any air bubbles in the filling material. This sets up rather quickly, and let it go ahead and set before you place the platelet-rich fibrin. It's very important that you have balanced vials. You don't want to just put one vial in. If you only draw one vial, you've got to put another vial in the other side across from your vial that you're using, filled with water. So it's got some weight. So it's really easier just to go ahead and draw at least 2 vials, but I normally draw an even number of vials, either 2, 4, 6, and then I don't have to deal with getting another vial and filling it with water. So you'll see the yellow clot in the top of this vial, and you remove the red part, you remove the blood part. So you should be able to pull this up. Now, if you only spin it one time, sometimes there's nothing to grab. There's no viscous clot. And that's when you need to spin it again for 8 minutes. So you place them on this tray. You can see it's a perforated tray. And then you put this plate on top of the yellow clots. And it flattens them and expresses the serum from the clot through the perforated trays into the bottom of the tray. And this serum is also rich in growth factor. So I'm drawing this up, and you can either use this to mix cancellous bone graft material, or in this case I'm just using it to squirt it into the socket. Then here comes my platelet-rich fibrin membranes. Just pack that in there. You just feel the healing with all that growth factor. Just plug that in, and then we're going to put one flat right over the surface. You can put a resorbable collagen membrane over this if you want to, but it's not necessary. 4-0 plain gut suture is sufficient for this. We don't need chromic gut. As you remember, plain gut resorbs in 4 to 7 days. Chromic gut resorbs in about 2 weeks, so we don't need 2 weeks. Like I said, this will probably end up being or having some recession where the fistula blew through the sulcus. Now I took a big bite on the flap, and then I'm going all the way through the papilla to the palate. Now when you go back through, it doesn't need to go through the tissue again. Just take the non-needle end of the needle, the blunt end that connects to the suture, and push that through. You can push the needle through the interproximal space there. You want to suture firmly but not tightly. If you put too much pressure on the flap, the suture will pull through. So I don't want a lot of tension on the flap. Reflect enough apically that you don't have enough tension on the flap. So you can see this is pretty gnarly looking where the fistula blew through the sulcus. And we'll just have to see how that heals. It may end up that the patient needs a gingival graft. Luckily, he has a very low lip line, and so cosmetics is not going to be a big issue here. Okay, so after a week of healing, we'll see if this granulates in. If it doesn't, then we'll come back and do a gingival graft there. So we've got about 7-8 millimeters of bone, and the tooth was class 2 bone mobility, stable, and I would expect this patient to have a nice life out of this tooth. I would expect 10 years plus, unless, if he's a big bruxer, it's important that he have a night guard. I think most patients should have a night guard just to protect from nighttime bruxing, and be sure he understands that he should not clench his teeth during the day. I'll have these patients hum. If you take a deep breath and put your lips together and your teeth part, that's where teeth should be during the day while you're awake. Teeth should never touch except when you swallow, and then just very lightly. They don't touch when you eat food, and they shouldn't be clamped together as you go through the day in the waking hours. So night guard, hum, lives together, teeth apart, good prognosis. And that's the Dental Minute.
Thank you all so much for joining us for this week's episode of the Dental Minute. Make sure you press subscribe right there, and we'll see you next week where we talk about implant-secured denture following extraction of decayed teeth. You will not want to miss this episode. We'll see you next week.